will come to order. Please read in would the clerk please read in the letter from Speaker Tate?
A letter from Joe Tate, Speaker of the House, dated January 12, 2023, to Mr. Rich Brown, Clerk of the Michigan House of Representatives. Dear Mr. Clerk, I appoint the following members of the 102nd Legislature to the standing committees for the 2023-2024 legislative session. Health Policy, Representative Rogers, Chair. Representative Whitsett, Majority Vice Chair. Representatives Reinigen, Miller, Fitzgerald, Neely, Farhat, Hadsma, Carter, Glanville, Conlon, Kofia, Vanderwall, Minority Vice Chair, Thompson, Mueller, Filler, Roth, Schmaltz, and Van Workum. Sincerely, Joe Tate, Speaker of the House.
Thank you. Would the clerk please take attendance?
Chair Rogers.
Here.
Representatives Whitsett,
I think she's on Zoom.
Carter,
Here.
Hadsma,
Present.
Neely,
Here.
Glanville,
Here.
Kofia,
Here.
Conlon,
Here.
Farhat,
Here.
Fitzgerald,
Here.
Miller,
Here.
Reingens,
Here.
Vanderwall,
Present.
Filler, Mueller,
Here.
Van Workum,
Here.
Roth,
Here.
Schmaltz,
Here.
Thompson.
Here.
Madam Chair, you have 17 members present. You do have a quorum.
Thank you. House Health
I
Policy.
am here. Sorry. I am here, though.
Thank you. Representative Whitsett. Yes, she's on Zoom. The House Health Policy Committee will follow the uniform committee rules stated in the House standing rules that were adopted on the House floor. Well, thank you so much. Thank you, Rep. Filler, for joining us. Appreciate your punctuality. And I did want to announce that probably Vice Chair Vanderwall and I will be having some friendly competitions. In fact, he was complaining about the elevator being a little bit slow, and I said, well, next time we'll be taking the stairs since it is the Health Committee. I am honored to serve as chair of the House Health Policy Committee and welcome you all to our first committee meeting of the year. Many of you know that I am a practicing physical therapist for over 20 years, and I have continuously been advocating for improved access to affordable health care for my entire career. I am continuing to practice physical therapy because my patients teach me so much every day that I see them, and they really inform me about many of the issues that they are facing. I am an evidence-based provider, and I am an evidence-based lawmaker. I intend to be inclusive in our deliberations and listen to patients, families, and providers first. I also served as a county commissioner for 8 years. During the Flint water crisis, I discovered that many communities, including my own of Kalamazoo, also had issues with children testing positive for lead. Some communities have water issues like Flint with the aging infrastructure of old lead pipes, but many, like mine, have a significant old housing stock with lead-based paint in the pre-1977 homes. Preventing lead poisoning will be one of my top priorities. I am very excited that our committee has the opportunity to create transformational change to improve the health and well-being of millions of Michiganders. I also recognize that our behavioral health system needs more support in our state. I am pleased that Speaker Tate has created a behavioral health subcommittee to specifically work on mental health issues, and I am pleased that Representative Felicia Brabeck, a psychologist, will be leading that work. A couple of housekeeping details. I appreciate those who requested a Zoom link in advance. Please do that the day before the meeting if you need it. I do appreciate as much communication as possible, and you should have received a letter from me earlier this week. I would like to introduce our first speaker, Norm Hess, with the Michigan Association for Local Public Health. And as a county commissioner, I do want to say I had the opportunity to see many of the services that our public health folks provide, from support services to our seniors to testing for the quality of food in our restaurants to keep everyone safe. Welcome, Norm. Oh, and before that, I am sorry I got so excited I skipped ahead. We do have one motion. Representative Carter moves to adopt Thursday at 10:30 a.m. in room 519 of the House Office Building in the normal daytime and location for meetings of the House Health Policy Committee. Will the clerk please take the vote?
Chair Rogers.
Yes.
Representatives Witset, Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kofia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingans,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller, Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 17 yeas, 0 nays, 0 pass. The motion is adopted.
Thank you. Mr. Hess, the floor is yours.
Thank you, Madam Chair and members of the committee, and I truly appreciate the privilege of your time this morning. My name is Norm Hess, and I'm the Executive Director of the Michigan Association for Local Public Health, which is a private membership association of all 45 local health departments in Michigan. Many people get confused about who we are. I will say that we're not associated with MDHHS, although many people think that we are. We are a private organization not affiliated with any governmental unit. So I'm here today to provide a very brief overview of public health services in Michigan. It's a very broad subject. Can't really cover it in 15 minutes, but I hope that you will reach out to us in the future and see MELF as a resource when informational needs arise. So in the 2 years that I have been with MELF, I have fielded many questions about what local public health is and what it does. These are some of the questions that are very common. Who does my health department report to? Where do they get the authority to do that? Why aren't local health departments led by doctors? What do they actually do? And are we prepared for the future, and what could make it stronger? So these are some of the questions I'd like to address during our time together. Before I get into a description of the system, I think it's important to note that from 1900 to 1999, life expectancy in the United States increased by 30 years. And according to the CDC, 25 of those years were as a result of public health interventions. Now, certainly there have been many scientific breakthroughs and advancements in clinical care that have also significantly contributed to people's ability to live longer and healthier. But it is important to note that public health is also a contributor to that trend. In 1900, public health interventions focused largely on infectious diseases, waterborne and foodborne illnesses like cholera, typhus, and polio. But as folks began to live longer, survive their childhood and early adulthood, many interventions have switched or changed focus to prevention and management of chronic disease, such as strokes, diabetes, and heart disease. More recently, public health has had a specific emphasis on working across sectors to meet the basic needs of individuals and change community conditions so that they can lead longer, healthier lives and so that future generations can be healthier. There are 2,800 health departments in the United States, and every state has a different way of organizing those services. In some states, all the local health departments are units of the state government, and they report directly to the state health department. In Michigan, that is not the case. We have what's called a decentralized system, and every health department reports to a local governing entity. So we have one city health department that reports to the city council in Detroit. We have 30 single county health departments depicted in gray on this map, and they report to county commissions. And then we have 14 multi-county districts serving from 2 to 10 counties, and they report to a local board of health, which generally is comprised of commissioners from each affected county and then sometimes additional folks representing the public. So these local health departments relate to various state departments of like the Michigan Department of Agriculture and Rural Development, Michigan Department of Health and Human Services, and Environment, Great Lakes, and Energy. Depending on the program and the funding that comes down to local health departments. So if you go to the Mouth website, you'll see this map, and you can hover over your county and you can get all the contact information for your local health department. Apologize for the wordiness of this slide. The good news is that you don't really have to read it. I'm just trying to illustrate that sometimes when people talk about essential public health services, they might be talking about two different things depending on who you're talking to. In Michigan, we have a list that it comes from the Michigan Public Health Code, which is PA 368 of 1978. And in the blue, you'll see the very minimum services that a health department has to provide in order to be a local health department. And those services are subject to the 50-50 state-local cost share requirement in the Public Health Code. On the right, nearly 20 years later, the CDC came out with a framework for local public health and called these 10 activities essential services as well. So sometimes they're known as the 10 core functions, but these represent activities that are far beyond those minimum basic services and really sort of drive public health as a field. So if you go to a national meeting or you're on the phone with your cousin in Ohio, they're never going to have heard of this list on the left, and if you say essential public health services, they'll probably be referring to the 10 essential services on the right. So I mentioned the Public Health Code, and it is a 732-page document. It takes a ream and a half of paper to print it out, so I didn't do that. But there are 3 sections that pertain specifically, well, at least 3, to this discussion. Part 22 talks about the State Department of Public Health, the structure and the duties of the State Department. Part 23 talks about those basic health services and the 50-50 cost share requirement. And then Part 24 talks about local health departments and the structure around and the requirements for local health departments, including the powers and duties, which I'll talk about again in just a second. There's a general misconception that local health departments exist to serve people with very limited incomes. Now, there are certain services that are focused on families or individuals that have limited income. But if you look at this list, you'll see that most of them are really targeted, if you will, to the entire residency of the county or the district. So if you're opening a restaurant or you're building a house or you're going to travel and need travel immunizations or you've ever ordered takeout or you like to drink water, your local health department is there to serve you. And you can also see that many of these activities are preventive in nature. And so when things are going well, public health often doesn't make the news because there's no story to tell. There were no chemicals that fell into the river. There were no children that had an outbreak of measles in a daycare. So that's why some folks are not as informed about public health, because oftentimes it's happening in the background, if you will. Just 2 more slides. One is about local health department leadership. There are many important roles in local public health. There are environmental health directors, there's nursing administrators, there's financial managers. But the 2 that I get the most questions about are the role of the health officer and the medical director. So the health officer, also known as the administrative health officer, is the one who is this kind of the CEO of the department, if you will. They oversee all operations and personnel, et cetera. They have to have specialized training in public health, according to the Public Health Code. They investigate health issues and hazards. They do a lot of working with other community partners in hospital systems, nonprofits, other governmental units. And when a health issue arises, they notify, they educate, they direct, and empower people to take steps to protect their health. Now, the medical director is also a very important role And every health department has a licensed physician with additional training in public health to advise on matters of public health policy, to create standards, and to direct the medical activities of the department. But it's important to note that the powers and duties of local health departments are assigned to the administrative health officer. They are the ones legally responsible for discharging those duties. So that brings us to our last slide, and it also kind of leads us back to one of our questions, which is public health prepared for the future? And I am sorry to say that, in my opinion, no, we are not. The COVID pandemic has strained the system in any number of ways. And even though flooding and resources and staff sort of came flooding in, it's kind of a temporary solution to a problem that's going to be with us. And it won't be long before we're back to where we were in 2020, or maybe even behind where we were, because our staff has, some of them have moved on to other sectors. We've lost a third of our health officers who retired or moved on for other reasons. The public perception is quite divided in their opinions of public health. Health officers had to make very difficult decisions, sometimes faced with option 1, which stunk, option 2, which was even stinkier, and option 3, which was the worst of all, and they had to choose which one they thought was going to save the most lives and prevent hospitalizations. And health officers were not immune to the ramifications of those decisions. Some of them had people in their families who were in nursing homes. Some had seniors in high school who played basketball and couldn't do that. So if anyone tells you that health officers were kind of doing this as a power trip or some sort of conspiracy to control people's lives, that is not the case. They went through this as well, not only as professionals but as family and residents. So workforce shortages, anybody who employs nurses knows that that's a problem, and in public health we have our own issues with that. And also environmental health sanitarians are a very difficult position to fill right now. They require a lot of training. We're doing lots of things to try and recruit. And then funding is something I could talk about all day, but I think that we maybe can save that for another day. But it is true that Michigan is ranked 40th in the country as for its per capita investment in public health. The essential local public health services have not been funded at a 50-50 cost share, so I have information on that. But I think that I will stop, and I hope that this won't be our only conversation that we have. I don't know if we have time for questions. I know there are other speakers.
I think we do have a time for a few minutes of questions, and I see Representative Ryan Gins.
Thank you, Chair. Thanks for being here, Mr. Hess. It's good to see you again. I've worked with Mr. Hess over the years in my previous career in public health in a variety of fields in health policy. My question was about whether or not we are adhering to Public Act 368 of 1978 and funding 50% cost share from the state to local public health departments, as is required by law, to fund the essential services. And I'm referring to the services here on your left-hand side that are under our state law.
So in my opinion, I'm not an attorney, but in my opinion, no, that is not the case. It is very clear that in 1978, when that law was passed, it said that the state would have a percentage of the burden and the locals would have a larger percentage, but over the first 5 years, it was supposed to come up to 50-50. And up until about 2017, the estimate was that the state was covering about 30 to 35%. It is now up to about 44.94%. But it's important to remember that those are just the contributions. It doesn't really reflect the actual cost of providing those services, and so that would require a pretty detailed analysis to find out how much is actually being spent on and how much it would actually cost to provide those 8 services.
Thank you. Vice Chair Vanderwall.
Thank you, Madam Chair, and thank you again for being here. Appreciate it. As we work on workforce shortages, suggestions on what you see this committee and what we can do legislatively to hopefully help in that situation. Do you have any knowledge that could help us?
Right. So I think that's a difficult question for this committee. There are some policies that have been made at the federal level for loan repayment and forgiveness and things like that. So we are trying to create sort of a multifaceted strategy to raise awareness of 6th graders and 8th graders of what public health is and how it might be a career path. As far as specific, I think we might have to do a little bit more work before we would have specific recommendations for this committee, but I will certainly reach out if we come to that point.
Well,
It's a difficult nut to crack. It absolutely.
It is, and I appreciate that, and I know that we've had some discussion in the past, and our number one goal here in the state is to make sure that our graduates stay here in the state and not exit.
Right.
And so any suggestions you have, we've dabbled around the edges, but it continues to be a major problem, and we know that proper health care is going to need proper staffing. So love to have the opportunity to chat with you further.
One of the obvious things is always that public health salaries tend to be lower than in other environments. And
All right.
so
Thank
if
you.
we can, yeah.
Any other questions? Representative Kafia.
Thank you for being here, Mr. Hess. I come from county government as well, and was a county commissioner over the past 4 years. I'm curious, do you have stats on the attrition of folks working in our public health departments who have left the field over the last years? It's been a tough couple of years, so when we talk about workforce, I was just curious if you've seen a trend. I know we lost our health officer in Leelanau Benzie
Right.
after the last 2 years, so just curious.
So I can tell you that 15 out of 42 health officers in the last 3 years have left their positions. As far as the rest of the staff, we are about to launch a survey to get that information. But I will tell you, kind of anecdotally, that some of our departments are saying that 50% of their staff have less than 5 years of experience in that particular local health department. So. Just before COVID and then throughout COVID, there's a huge turnover, but I do not have the actual number for you right now.
Representative Rankins.
Thank you for letting me have a second question. Could you explain some of the fields of study that an individual might need to join the field of public health, especially in local public health departments? Just a few types of fields,
Yep.
if you would like to list them, so we can think about that as we're developing policy.
Right. So there are specific requirements for both, health officers, for instance, need to have a Master of Public Health degree and a certain number of years of experience, or a related degree and then more experience, or in certain cases, they could have a bachelor's degree and 8 years of experience. Medical directors have to obviously be licensed to practice, and then they also have to have a Master's of Public Health degree, because those are two different, being trained as a physician and being trained in public health, very different things. We also have social workers. We have people who have degrees in psychology. We have, people come into public health from a lot of different areas, and so then we as an association, do a lot of training to make sure that people are understanding the tenets of public health.
Thank you. Well, we really appreciate your information. Thank you so much. I think we've got probably some follow-up questions for you later, but we appreciate you coming and kind of uplifting the whole menu of options. I know it's just scratching the surface, but appreciate your time and
Thank you so
uplifting
much.
those.
Thank you all.
Next up, we have a presentation from Michigan Primary Care Association, and to present their organization, we will have Ann Scott from the Health Centers Operation Officer and Chris Drake, Executive Director of Ingham Community Health Centers. Welcome. whichever you prefer, just make sure you turn the microphone on. I think the other one might still be on, but.
I think it works. Great. Well, good morning, and thank you so much for having us. We really appreciate the opportunity to share about community health centers, and especially community health centers as we're emerging out of our COVID-19 pandemic. So I'm Ann Scott. I'm with the Michigan Primary Care Association. This is Chris Drake. He is with the Ingham Community Health Centers right here in Lansing, a wonderful health center. MPCA, we are a membership association that represents all 40 community health centers that are operating here in Michigan, as well as 4 Native American health service providers. And these entities are local, patient-centered healthcare organizations that provide care to people who are low income or in medically underserved communities all across the state, rural and urban. We provide high quality, affordable, and comprehensive medical services to everyone, regardless of who they are, their insurance status, or their ability to pay. And those services are comprehensive, meaning that we provide both medical services, oral health, behavioral health, and substance use disorder, and more. But those are some of the core services that you'll see across health centers in Michigan. We provide whole person supportive services, so that includes things like transportation assistance, language and interpreting services, care management, and that's really intended to surmount the barriers to care that people have and really bridge people into staying engaged in their health care and achieving their best possible health outcomes. So what community health centers do, we are accountable, cost-effective healthcare providers in, as I said, low-income and medically underserved communities. But we also are economic drivers in those communities as well. So first of all, health centers have a federal designation and get federal funding to provide the services, and that's what helps us provide a lot of those supportive and bridging services. And with that, we're highly accountable. So we have to adhere to administrative, clinical, and financial requirements, and we're pretty accountable for our service delivery and our performance in healthcare in our communities. The other thing to note is that we are cost effective. I like to say FQHCs really make Medicaid work. We're extremely cost efficient in care. We tend to serve patient populations with higher proportions of diabetes, hypertension, and chronic conditions, but we actually perform better on their clinical outcomes. So we have more diabetics, we have more people with hypertension, but those folks, we have more of our patients who are in control than in other primary care settings. And we save a lot of dollars. So on average, we save about $2,300 per Medicaid patient. That's about 24% savings versus Medicaid patients receiving care in other primary care settings. The other thing I'll note is that we're an economic driver. And what I mean is, and this is a great segue from the conversation about workforce, health centers employ over 6,000 people across Michigan. Again, we're based in low-income and medically underserved communities, so we are providing economic opportunity in those communities as well. We generate about $1.3 billion in economic stimulus in those communities that we're based in. I'll just make a quick mention. One of the programs that we support health centers with is actually a Grow Your Own, Earn As You Learn training program for some of these positions that really got knocked out during the pandemic, and that's seeing a lot of success, and that's creating job opportunities for people living in the communities we serve. Coming out of COVID, and Chris will say much more about this, but I think one thing I want you to know is that health centers were really the backbone of the safety net. We were there making sure that access to primary care was sustained all throughout the pandemic and delivering COVID services, testing, vaccination, treatment linkages, and care. So we really did everything we always do, and we did more. And it was a huge, huge ask, but health centers really rose to the occasion. And I think the other thing that came out of that is a recognition that health centers are part of our public health system and are part of that public health emergency response. We had relationships established with homeless populations, migrant and seasonal farm worker families, and we were able to reach people that were hard to reach with COVID services during those critical times. I'm going to turn it over to Chris to share a little bit more about what he really does at health centers.
Thank you. Good morning, everyone, and thank you for having us. As noted by Ms. Scott, health centers play an essential role in keeping the most vulnerable populations across the state of Michigan on a path to a higher quality of life. Health centers meet people where they are in life and serve as a one-stop destination for people we serve. Health centers are able to function as one-stop destinations by offering a variety of services. A typical portfolio of service offerings by health centers of all sizes include primary care, behavioral health care, dental care, pharmacy services, and wraparound resources to attack and address socio-determinants or influencers of health. Health centers of larger size and complexity may offer additional services such as pediatric care, women's health services, vision care, school-based care, infectious disease programs, and select specialty service offerings including but certainly not limited to dermatology, podiatry, and substance abuse programs, to name a few. But regardless of the health center's size and complexity, one truth remains clear, and that is, we serve all who walk through our doors, regardless of their ability to pay or their insurance status. But like many organizations across the state and country, health centers have had to reinvent themselves during the pandemic, plan for sustainable organizational life beyond the pandemic, and press on towards a rather uncertain future. However, a few challenges remain, and I would like to take this opportunity to discuss two of them with you. First, as you heard from our previous presenter and Ms. Scott, workforce shortage. As an industry, healthcare organizations are struggling to not only find, but also retain a highly skilled workforce to deliver on their respective missions. Physicians and nurses are not as plentiful as they were in yesteryear. Quite simply, we need to address the workforce supply issue as soon as possible. Otherwise, the healthcare industry will gradually and eventually collapse. In addition, health centers struggle to compete with larger corporations on recruiting and retaining talent. Let's face it, larger corporations are able to offer more competitive compensation packages. But this is a good segue to another area of concern, namely long-term financial viability. Financial viability is a long-standing issue for health centers. Given that the majority of our patients are either Medicaid beneficiaries or uninsured, our financial solvency is heavily dependent on Medicaid reimbursement, right? And unfortunately, as Ms. Scott noted, Medicaid reimbursement does not offset the operating cost of delivering care in health center settings. What's more, the American Rescue Plan Act funding for health centers set to expire on March 31st, 2023, creating additional financial uncertainty. But some solutions to this long-standing issue may include higher levels of reimbursement from Medicaid and additional, yet sustained, grant funding, to name a few. Yet I deem it important to note that health centers will continue to do their part in this journey by trying to optimize their cost structures without compromising quality of care, customer service, patient, and workforce safety. Yet, as the saying goes, no margin, no mission. And so finally, I will end with these kind words. If you ever are in need of assistance, please know that I am located in the greater Lansing area, and I'm more than willing to serve as a resource. And so with that, we thank you for having us. We'll yield our time.
Thank you very much. I do think we have a couple member questions. I have my own to kick off. So you touched on that March 31st deadline. Because the lion's share of your patient population is Medicaid, insured by Medicaid, what kind of impact are you anticipating that this is going to have if nothing is done? My understanding is that it's quite a large chunk of Michiganders that will need redetermination. And just for those on the committee that might not be familiar with this, the Medicaid redetermination period was paused during the pandemic, is my understanding. And so I'd just like you to comment on what kind of impact this would have. And both of you can comment, or either.
Sure. So yeah, Medicaid redetermination is going to start April 1st, and we're working closely with MDHHS on their plan and their timeline. And that'll take place over the course of about 12 months. So as people's redetermination dates come up, we're going to kind of go through this process of redetermining eligibility. So some people will retain their coverage, and some people may be found to no longer be eligible for Medicaid, which may mean they will either become uninsured, or we can hopefully help them transition to perhaps a marketplace plan or another form of coverage. I want you to know that health centers are, we've been planning for this for probably over a year. We knew when the PHE ended that Medicaid redetermination was going to be a challenge. Over 50% of our patients are Medicaid, and we serve over 715,000 people across the state. Okay, so it's a big chunk of folks. So we've got a lot of skin in the game. Health centers right now are working hard to communicate to our patients. Make sure their information is up to date in MyBridges. Make sure that they're prepared, that they're looking for mailings and notifications. Our big goal right now is to make sure that we mitigate as much as possible people who are going to continue to be eligible. We don't want people to fall through the cracks. If they're still eligible, we want them to keep their coverage. Disruption to coverage means they get gaps in care. Even though we're here and we'll serve you whether you're insured or not, sometimes people think, oh, my coverage has lapsed. I'm not going to be able to afford my meds, and they don't come for care. So we've got a lot of information and messaging that we've got to get out to the Medicaid population to let them know that don't despair. Health centers are here to help. We have enrollment staff ready to help, but it's going to be huge. It's going to be a big ask. There was a study that came out the other week, which I can share with the committee, that I think estimates that about 60,000 Michiganders are probably, that's just patients in the health center community that are going to be impacted, losing coverage potentially through the redetermination. So that's a big chunk of our patient community.
Thank you. Chris, did you have any further follow-up to that?
I will simply reiterate what Ms. Scott said. The health centers across the state are working diligently to get out in front of this issue. We recognize that we serve a population that's oftentimes very difficult to reach, yet we have the resources to be as successful as any agency of establishing that connection and making sure that they don't fall between the cracks. So we will do our very best.
Thank you. Thank you very much. I see Representative Hadsma has a question, and I'm so glad he's here with us because he chairs the Labor Committee, and I think he's going to solve all your workforce problems. Rep. Hadsma.
Yay.
Thank you, Chair Rogers. I have a question, Ms. Scott and Mr. Drake, that really is Representative Vanderwall's question to Mr. Hess. Where I come from, the federally qualified health center has a lot of turnover in relation to health providers, and it sounds like that's true of many of the federally qualified health centers around the state. What specific recommendations, as Representative Vanderwall asked Mr. Hess, might you articulate to try to get more constancy and stability in the workforce in these federally qualified health centers?
Great. Yeah, thank you for that. Well, I could start and talk a little bit. I think key things is investment in workforce programs. So we at MPCA, as I mentioned before, have really gotten engaged in some of the workforce programs and funding resources that are available, like the Going Pro Fund, starting some programs to help people do on-the-job, earn and learn, apprentice-style training programs for a lot of those fields. I think there's more potential to grow there. We've started with medical, dental assistants, pharmacy techs, but there's opportunities, and we actually have a pilot right here in Michigan of doing apprentice-style programs even for nurses, hygienists. Behavioral health is another key staffing shortfall area that we desperately need. And so I think innovation of thinking outside the box about how we train those professionals, how we grow talent from within the communities, and that goes all the way up to the provider level as well. And health centers are working to get more engaged with training programs to both help people from particularly like rural Michigan. It's hard to get providers and dentists to move to rural communities. But if we can find opportunities that provide the funding and the training experience in the communities they're from, they're more likely to stay and serve. And we've got examples of that in FQs.
The only additional statement I will make is health centers have to hire for fit. And what do I mean by that? It takes a certain heart to step into this environment and remain here. It's not just a job, it's a calling. And so as we press forward and try to solve these very complicated workforce shortages, we have to make sure that we have the right people on staff. It's not just a job, it's a calling.
Thank you.
Any other questions? Rep. Brian Gins.
I wanted to add on to the Medicaid redetermination question. I'm assuming FQHCs are establishing a plan of how to communicate with patients that despite some difficulty enrolling on the healthcare marketplace in past years, some subsidies weren't enough. Thanks to federal legislation and funding, there are increased subsidies for plans on the marketplace. If people are rolling off of Medicaid and need to get on the marketplace, there's higher subsidies than there were before. Is there a statewide communications plan, or is that included in your communications plan?
So right now, we're really trying to work in coordination with MDHHS on the messaging and also with other partners, our public health partners, the Michigan Hospital Association, the Health Plan Association. I think this is an all hands on deck, and we're trying to make sure we have clear, consistent messaging so we're not creating confusion out there in messaging. So we're really working to try to align messaging and make sure that we're working in coordination, and I think there's effort to do so.
Representative Carter.
Thank you, Madam Chair, and thank you both for your testimony today. Excellent. I do have a question about that redetermination period. Now, after a long period of not having to go through redetermination, all of a sudden a lot of Medicaid recipients will have to go through it. And I fear that it's going to be projected a lot of people will lose their coverage. What are you doing to get ahead of that? And then the secondary question, follow-up question to that, something that's very near and dear to my heart, which is serving the homeless population. Where if our homeless population is in danger of losing your help as well, what safeguards can we do? What would you suggest that we look at in order to get ahead of this? Thank you, Madam Chair.
Oh, thank you so much for that question. So maybe the first part of your question, which is, maybe I'll take the second. So we do have reach and serve a lot of homeless populations. So, right, 3 years of time. So people have not gone through redetermination since 2019. Many new people were added to Medicare, or Medicaid, so they have not gone through this before. So they don't even know what the process is. So there's a huge amount of education that needs to happen for people to be aware of the redetermination process, how it works, and what they need to do in a timely way to retain their coverage. And people have moved. Their family sizes have changed. Their income status has changed. There's just been a lot that happens over the last 3 years for all of us. So there's a lot of education that needs to happen. I guess what I'll say is health centers, I think we know how to do this. We have done this for years. But we need help. We probably need help from all of our partners. We need a clear plan from MDHHS about the process itself so that we can reinforce and support it. And, you know, I think financial challenges and staffing challenges are our inhibitors. So if we don't have enough funding to hire the enrollment workers, the outreach workers, the community health workers that often do that sort of in between, fill in the gap support, that's what inhibits us from doing the reach we need to do in the education and community communication that we need to do with our patients. It's going to be a monumental effort. And we've got very hard to reach folks. And I think our homeless population is one of those key populations where loss of coverage and disruption of care, that's what we really want to avoid. Is we've got good control of our hypertensives and our diabetics. We don't want them to go a couple months without getting care just because they had a coverage blip and thought they couldn't get care.
Well, thank you so much. Oh, go ahead. Final comment, Chris?
Again, we are preparing for any particular outcome. But as I said in my remarks, we will continue to serve individuals regardless of their ability to pay. That's the unique nature of community health centers.
Thank you so much to both of you for presenting. Please know that you have my commitment to do what I can to help with the situation with the, I would call it a cliff. I think it is significant. And in the coming weeks, we're going to have DHHS in here to present too. So thank you so much for your partnership. Appreciate it.
Thank you very much.
Thank you.
Next, we will be hearing from Laura Oppel, Executive Vice President of Advocacy for Michigan Health and Hospital Association. Welcome.
Good morning. So, Madam Chairwoman, Vice Chairs, and members of the committee, the MHA thanks you for the opportunity to make these comments today. As she mentioned, I am Laura Oppel. I'm an Executive Vice President at the MHA, and I'm part of our MHA policy group on public health. So, just quickly, the Michigan Health and Hospital Association represents every hospital in Michigan. If your local hospital has an emergency room, they are a member of the MHA. And we would be remiss if we didn't mention that our members, your community hospitals, care for everyone who walks through the door. So I'm going to talk about the overlap between public health and the healthcare delivery system specific to hospitals. The state and local departments take the lead on public health. But hospitals bear the cost of poor public health, and lack of funding in our core public health programs slowed our response to the COVID-19 pandemic, exacerbated its impact, particularly in low-income communities, communities of color, and for older Americans. In the first days of the pandemic, you'll recall Southeast Michigan was among the hardest hit areas of the country, and our hospitals quickly filled with patients in the emergency department. Then they went to the intensive care units. Then they were on ventilators. Nurses, respiratory therapists, doctors, and our environmental, food service, and transport workers were all quickly exhausted with the overwhelming need for patient care. Today, we're familiar with healthcare miracles like transplant surgeries and life-saving trauma care. But as Norm mentioned earlier, the largest gain in life expectancy in the United States was due to public health improvements, such as control of infectious disease, clean water, and other non-medical social improvements. And this was all before we had antibiotics and advanced surgical techniques. So these improved sanitation, public water treatment, food inspection, et cetera, virtually eliminated those causes of death. These interventions, I want to point out, were implemented broadly and not with personal or individual interventions, or as I like to say, we didn't assign sewers individually. We made it for everybody. The increase in life expectancy was also enhanced by the explosion of vaccine development. Whooping cough, tuberculosis, and diphtheria all came before 1930. And then, of course, we got polio in the 1950s. But it was public health efforts that got those vaccines in people's arms. Now, those are done individually, but the greatest impact happens when we have comprehensive uptake. When the COVID-19 vaccine became available, you might recall that we had a West Michigan vaccine clinic in Grand Rapids. That was a partnership of the Kent County Health Department, what was then Spectrum Health, and Mercy Health in Grand Rapids. They delivered more than 200,000 doses of the vaccine between the end of January and the end of April. We also took the lead in delivering monoclonal antibodies, which were one of the first effective therapies available for people with COVID-19. That treatment requires intravenous delivery, and it's an infusion that takes more than an hour. So you don't need to go to the hospital exactly, but this is not something that public health is going to be able to achieve on a broad basis. So those are two wonderful examples of our successful intersection between local public health, the state health department, and our hospitals and health systems. And vaccination remains a critical partnership between public health and healthcare. And I think everyone on my side of this would agree that we're seeing great evidence that physicians and other clinicians who have the skill to build trust for their patients are most important in terms of getting people to return to childhood vaccination. So the MHA has recently developed a task force on public health, however, and we did this because we want to know how can we best support the reinvigoration of public health policy, improve funding, as Norm mentioned, we could talk about that all day, and build public support for public health. And we learned as part of the conversation with our local public health representatives that the data sharing that we've been doing was not as successful as we might hope. So we're reporting daily on the number of beds available, intensive care beds, ventilators available, and there are differences between the number of beds licensed and the number of staffed beds. And that has to do with the number of workers we have. That rises and falls. You'll recall there was a time during the pandemic that we had many healthcare workers who couldn't report to work because they too were infected. So in response, for example, to combat this difficulty, we're creating a dashboard on our website with graphics to help our local public health partners better understand what's going on in their communities by posting hospital admissions by flu and COVID admissions for hospitalization and by age. So I just want to talk about a couple more things. One is health equity, and we have a second task force specific to health equity. We have dismal statistics on the severe maternal morbidity and mortality for Black women in Michigan. From 2015 to 19, Black women were nearly 3 times more likely to die from pregnancy-related causes in Michigan. We are focused at the MHA on finding ways to eliminate this specific health disparity of care, and we will work together with our public health partners to further reduce the incidence of chronic disease, eliminate the lack of knowledge among all pregnant women related to treatment and follow-up, and confront the conditions which result in delays in seeking or providing care, which we believe are part of the root of these poor outcomes for women of color. In other areas of the state, indigenous women have similar poor outcomes for other conditions, or for pregnancy, but pregnancy-related, not, or pregnancy-associated, not pregnancy-related. Those working in health and healthcare are not experts in education, however, or employment, transportation, food security, or the other social factors that create hurdles to good health and are part of what create health inequity. So I want to make it clear that we are partners in this, but achieving change to improve the health of individuals and in turn create healthy communities requires comprehensive and coordinated policy work beyond public health and healthcare delivery. And then finally, after the conversation earlier about Medicaid redetermination, we absolutely agree with that concern, both from our colleagues and from the committee members today. We had already been working with other associations on ideas for some funding to prevent the loss of coverage or disruption of care, and we'll be back in touch with the chair very soon to share that with you. So thank you, Madam Chairman, and I'll for your time today, and I'm done.
Thank you. Really quickly following up on that, can you just give us a flavor of what kind of impact do you anticipate the Medicaid redetermination process having on hospitals in Michigan?
Well, before before the maintenance of effort to not have redetermination, we had about 2.5 million people enrolled in Medicaid. Now we have just over 3 million. So how many of those people do need to stay on? I don't know. The loss of coverage for potentially 500,000 people would be very difficult. There are some things that give me hope for better outcomes. Some things change at the federal level. Health plans are able to share addresses with our State Department now. We just got, in our state a couple years ago, we have decided that women who are postpartum will get a full year of coverage, which is important. You might not know that the average time that we find out that someone has postpartum depression is 6 months after birth. So ending coverage 60 days after birth, giving birth didn't make much sense, so that's terrific. Children, I think we already had this policy in Michigan, children have a full year. Once they are decided to be eligible, they get to stay on for a full year. And then finally, this is not ideal because if people don't think they have coverage, they often don't present themselves for care. But when you do present yourself under Medicaid expansion, our Healthy Michigan plan, we can do presumptive eligibility and get people re-enrolled very quickly. But we would prefer to not have anybody have that coverage disruption. We would prefer that if they are no longer eligible for Medicaid, we find a way to get them into a zero premium plan off of the exchange and coordinate that way. And we've seen some ideas from other states, and we also think that we could reinvigorate perhaps like the Navigator programs.
Thank you. Representative Filler?
I'd like to talk about staffing. I know it's going to be an issue for you. I know it's going to be an issue for basically every group in the healthcare field. Do you have any initiatives or anything you're working on, either pilot programs or statewide, that maybe this committee would like to hear about?
Yes, great suggestion. We too believe we've had members take advantage of Going Pro. We are excited that the most recent change in the My Michigan Reconnect program allows for not just community college degrees, but certificate programs. So if you have people who need to get to work quickly, we can get them trained in a matter of weeks or months to be phlebotomists, to be pharmacy techs, to be lab techs, to do sterile instrument preparation. I had a conversation with the staff from Senator McCann's office, and they said, can you write a newsletter article for us? And I thought, that is a great idea, and I can give it to everybody, because everybody, I'm sure, has people in their community who could take advantage of that, because you can do that without having to pay the cost of tuition. Now, I know there are other barriers. We also have the opportunity now, you know, an LPN is a community college degree. So if you're already a patient care tech, you can use that community college benefit to become an LPN. If you become an LPN, you can get a community college degree to be an RN. We also got funding to have four-year institutions offer RN degrees or BSN degrees at the community college level. So now that's not covered by Michigan Reconnect, but that makes it much more available. You don't have to find a four-year institution to go to. Community colleges are more, they're spread out further. And we also at the MHA, in a number of weeks, you will see us launch a healthcare careers campaign to make people aware of what is available out there. You might have seen in the past some graphics that say what people think a hospital is, and it's a big building with nurses and doctors inside of it. And what a hospital really is, it's a place with numerous career pathways, and we need dozens of people or dozens of types of job classifications to really make it work. So lots of things going on. In terms of recruiting staff, we have conversations with, I actually have a conversation later today with Business Leaders for Michigan. We have a regular conversation with our higher education folks, post-secondary, Leo, et cetera. So we're all in on talent. Thank you.
Thank you. Vice Chair Vanderwall.
Thank you, Madam Chair, and thank you for being here. Just a couple quick questions. You discussed a little bit about childhood vaccinations, and we know that we had a serious fall off on vaccinations during the COVID and the closure of schools. Have we seen an uptick in that, or are we still struggling to get back on track?
We are absolutely still struggling, and it's going to sound like MHA just has all we do is create committees and councils, but we have a lot of work to do, and we have a lot of people interested in doing it. And we actually have a Council on Children's Health. It's populated with many pediatricians, and this is probably among their highest priorities. They only have a few, and this is one of them. And we're actually, Dr. Natasha Bagdasarian, our state medical executive, we're convening some special meetings with her to try and figure out how we get back to those better rates we had. Our rates were never what we wanted them to be, and they're a lot farther below that than than they were before. The other thing that we're learning, however, is it's not like, I don't think it's like when I was in school and they said if you need the measles booster, which I think happened when I was in high school, that we're going to do that in the gym at 10 o'clock on Friday, and everybody we all just like went and lined up. Now people want to know more, and they want to do that with their pediatricians. And not all pediatricians are like, oh, great, I'll just keep vaccine in my office, and I'll set appointments for that, and I'll take time to explain to all of my parents who want to know about that. So we really need to figure out how we can support them as well, so that while they're the trusted voice, we are also giving them the resources they need to exercise and be active as that trusted voice.
Very good. Thank you. And then, Madam Chair, one quick question. You'd mentioned the pregnancy coach, and I know that it's implemented in a couple different areas throughout the state. What have the benefits been? I know in certain regions it's been tremendous. And what is holding us up from being able to promote that statewide?
So we have not been as involved directly on the pregnancy coach angle, but here is what we are seeing in our data, which is we actually have one of our hospitals that has among the highest rates of Medicaid covered births, is doing among the best in outcomes. So it's not necessarily low income. There's more to it. And there are bundles of interventions that we study at the MHA, and what we're starting to think is it's not a one-size-all of these interventions, and we really have to figure out more directly what is lacking in this area of the state where outcomes are poor compared to if we do the intervention here and it works really well, and we do the intervention here and it doesn't. And we're going to have to, when we did, for example, I could talk about this, again, a long time, central line associated bloodstream infection prevention. It was a checklist. You do this, you do this, you do this, you do this, and it's going to stop. That is not the way this intervention works on improving our rates of severe morbidity and mortality. So it's going to be a deeper dive than that. But we've hired new staff to help us work on this, and we work very closely with the Council for Maternal and Child Health, and I think we're going to get somewhere, and we appreciate we've had new funding come to us on this as well. So thank you.
And probably our last one of the day, Representative Carter, and then we'll close it out.
Thank you, Madam Chair, and thank you for this very informative discussion. I want to go back to Black mother mortality rates, and just one simple question. Have you seen an increase or decrease in mortality rates since 2019?
So I was looking at some graphs yesterday, and there was one graph that looked stunningly bad, really took my breath away, and I thought, oh my God. And then I read, well, this graph has changed because of the way we're counting. So I can't adequately answer your question today because I don't know what the change was. I mean, sometimes, I remember in crime statistics, we used to not report crimes against women too much, and so we saw very large increases in those crimes. But was it because we had more crime or because we finally started talking about it? And so I can't answer your question today. We were really doing in the first part of the 2000s better at this reduction, and things came back up, and I would say we've seen this bouncing back and forth. We have never gotten back down to where we were before, and it is, it's an embarrassment that we haven't, and but I know there are many, many people who it's not for the lack of their trying, but we are we are not performing adequately by any means.
Thank you for your,
Yeah, yeah. There's a
That's
great,
right.
the state has a great website that we can get to the chair and share back with you, and it's really easy. I mean, it's very accessible in terms of you don't have to have a lot of expertise. I mean, I can figure it out, so, and I'm not clinical, so that's.
okay, thank you so very much. Thank you, Madam Chair.
Thank you. Thank you, Laura, for your presentation. Thank you to the committee members for being present today, and thank you for also wearing red. We're going to do a group photo real quick afterwards if you would like to participate in honor of Go Red Day tomorrow. We were going to do it today, but it's no attendance, no voting, and I'm sponsoring a resolution on Heart Disease Month for February. So there being no further business before the committee will stand adjourned.